This is the BIOS Centre, so we're a bioethics research centre. We're very much reliant on donations. We run on a shoestring. So if you do like our work, then please, I think appearing in the chat will be a donate button. So I'm saying that in advance. So if anybody want to contribute towards our work, then we're extremely grateful and let others know about us. So tonight we're very pleased to be able to welcome Professor Dr. Thomas Finegan, who's an assistant professor in theology and religious studies at the Mayor Immaculate College, and he's also chair of the board of governors of the Anscombe Bioethics Centre, which is based in Oxford. And the reason he's talking to us tonight is a recent article he wrote in the New Bioethics, which is extremely relevant at the moment, particularly for UK or England, Wales citizens concerning Kim Leadbitter's bill. The paper by Thomas Finegan was Assisted Suicide and Slippery Slopes, Reflections on Oregon. Of course, Oregon is extremely relevant to proposed legislation here. So without further ado, I invite Dr. Thomas Finegan to address us.
Thanks very much, Anthony, and hello everyone. Great to be speaking to you all in this forum with BIOS among friends and interested parties. So thank you very much for the invitation. So just recently I published that paper that Anthony referred to in the introduction, and the cause of studying for that paper, or spending time on that paper, was my own appearance before an Irish parliamentary committee towards the tail end of last year. I was invited to give evidence in relation to our own assisted suicide bill, which I did. And in the course of researching that, it became very clear that the test case of Oregon was one on which a lot of different issues and cases hung. So I thought it wise to go through the official data provided by the Oregon Health Authority on the operation of its Death and Dignity Act, which has been running for quite a considerable number of years now at this point. And in the course of that, I uncovered what I thought was some interesting information that maybe acted as a corrective to some of the points being raised in relation to Oregon in the context of not just Irish debates, but also UK debates and further afield, indeed. So one of the primary interests I have, probably the main interest I have at the moment in relation to assisted suicide, is the issue of slippery slopes. I'm very interested in moral normativity and the moral logic behind different positions, whereby if certain principles are conceded, what that at least moral logically entails down the road. And obviously that's a matter that is certainly relevant to assisted suicide, because the slippery slope argument, I suppose, is very much at home in assisted suicide debates, and with good reason, I think. At the outset of the paper, and indeed my presentation, to the Oireachtas committee in question, I talk about assisted suicide in the context of slippery slopes. There's two kinds of slippery slope argumentation that you'll find in the works of people like John Keown. For example, one is the moral logical version, which is the one I'm most interested in. The idea that, well, if you concede that it's at least in some instances permissible to deliberately end a patient's life in the form of assisted dying or assisted suicide or voluntary euthanasia, therefore one has conceded a particular principle, and it's not easy to non-arbitrarily and consistently cut off the qualifying grounds. So even though a lot of these things were introduced on the basis of very narrowly drawn exceptions, such as terminal illness with death likely to occur within 6 months, in moral reality, such exceptions are extremely difficult to justify according to the basic logic behind the provision of any kind of assisted suicide at all. The case of Oregon comes in more so under the empirical version of the assisted suicide slippery slope argument. The idea being that, well, in jurisdictions that have allowed this, what's tend to happen over time is the expansion of grounds or case numbers or so on. And that holds true for most jurisdictions, unquestionably. I mean, the data is in, and it's only going one way. But Oregon is an outlier, or it seems at least to be an outlier, because assisted dying there has been legal for the guts of 25 years. and there's been no de jure amendment or expansion of the law. It remains on the basis of terminal illness with death likely within 6 months. And that hasn't changed. So a lot of proponents of assisted suicide look to Oregon as the model on which they want to base the legislation they're introducing. That's certainly the case in Ireland. I think my understanding is that's the case in England and Wales at the moment with the bill before you. And you could say, well, look, there's political reasons for this and so forth, and there undoubtedly are, why you'd introduce a narrowly drawn bill. But proponents would generally say that there's something principled about such a narrowly drawn bill, and that Oregon at least provides precedent for such legislation becoming operative and not expanding. So that's the sort of thing that I wanted to look at. And when I examined the official reports provided by the Oregon Health Authority, it became clear to me that even though there's been no de jure expansion, no formal legislative amendment to expand the grounds on which assisted dying was available, there is still most certainly expansion occurring in Oregon. And what I find most fascinating about that is that expansion is happening within the confines of a very narrowly drawn law that hasn't been formally amended, and yet it's still happening. So I'm just going to read out the actual qualifying ground from Oregon, which is similar to, yet not again identical to, the Leadbeater bill. So under Oregon's Death with Dignity Act of 1997, assisted suicide is accessible only on grounds of terminal illness, defined as, quote, an incurable and irreversible disease that has been medically confirmed and will, within reasonable medical judgment, produce death within 6 months. Okay, and as I said, there's been no expansion of that according to formal legislation. There certainly has been expansion, though, in terms of case numbers, and I think that's important, for sociological reasons, but also in terms of understanding the impact that a law like this can have on wider society and norms within society. So in the first reported year, provided by data from the Oregon Health Authority, which was 1998, 16 died by assisted suicide. And in the second, 1999, and third years, 27 died. So if you compare those numbers with the following, in 2020, 259 died. In 2021, 255, and 2022, 278. That's the figure that I have in my paper, the figure of 278 for 2022. In actual fact, and I'll kind of speak to the updated data provided by Oregon as I go through this presentation. The corrected number for 2022, according to the 2023 report, it was 304. In my paper, I intimated that that number would likely be revised upwards. I suggested a figure of 15 or 20, which wasn't very far off, but it was an underestimation rather. So what that represents is over a tenfold increase in 25 years. But even probably more importantly, it also represents a very, very significant acceleration in the number of cases per year. So it took 17 years for the annual figures to pass 100 cases. So it took between 1998 and 2014 for that to happen. Then 5 years thereafter for the annual figure to pass 200, and that occurred between 2015 and 2019. On the current trajectory, I said in my paper, it would take 3 years for the annual figure to pass 300. In actual fact, in the space of 3 years, it's almost past 400, because the figure for 2023, which was just published there a number of months ago, is 367. So again, it's really clear you've got not just an increase in numbers year on year, you've got a really pronounced acceleration in numbers year on year, especially in the last 5-6 years. And the direction is very obvious. And obviously, there's no other way of interpreting this data other than to say that what's happening in Oregon is social normalization. You could also say medical normalization. I don't think shift in demographics explains this marked increase. The population in Oregon has risen but only from 3.28 million to about 4.25. So that doesn't explain it, even if it's becoming an increasingly older population. I still don't think you can explain this really pronounced acceleration in cases year on year, especially over the last 5 or 6 years or so. So this brings me to the question then of socially what's happening. And obviously, one of the things that's happening is that this is becoming more acceptable. That's however we're trying to explain the numbers, that has to be part of the explanation. But there's something else happening when you dive into the data provided by the Oregon Health Authority, and that's a change in attitudes towards assisted suicide in the context of someone feeling a burden on others. For example, when I was at the presenting at the Oireachtas, the Irish Parliament's Committee on Assisted Suicide, I had need to go through the different proceedings both before and after I had presented, and one of the people presenting was the current head of the Oregon Health Authority, Dr. Tom Jean, and he talked a little bit about this issue of people choosing assisted suicide for burden-based reasons. So he described the figure of, which is provided by the data, of roughly 47 or 48% of people who choose assisted suicide in Oregon doing so in part because of burden-based reasons. He described that figure as only 47 or 48%. And he said this, quote, "I do not see that as a particularly concerning figure. Among a handful of concerns that somebody with a terminal might cite at the end of his or her life, being a burden to his or her family would seem to be a reasonable one." And then the number of people citing this as a reason has shifted. So the first number of years, first 3 or 4 years, only about 35% of people availing of assisted suicide in Oregon were citing being a burden as a reason to choose assisted suicide, but that's now increased to roughly 51 or 52% of people, Oregonians, choosing assisted suicide, citing being a burden as a reason for their decision. In the first ever report produced by the Oregon Health Authority in 1998, it explicitly addresses the issue of choosing assisted suicide under not coercion, but under the idea that one is a burden. And it presents a very heavily negative attitude towards that. It's very clear from the first official report produced by the Oregon Health Authority that that is something that the law wasn't instituted to permit or to encourage. And that tone, and indeed those remarks in that 1998 report, contrasts quite sharply with how Dr. Tom Jean approached the issue of burden-based assisted suicide just last year. Certainly a shift seemed to occur in terms of official positions or official narratives at least, or at least official messaging. And that's reflected in an increase in the number of people availing of assisted suicide for burden-based reasons. What's perhaps maybe most interesting in relation to Oregon is how in practice the qualifying terminal illness ground is being treated. So obviously, as I've called it out there, and indeed as it might appear in the Leadbeater bill, the qualifying ground of terminal illness it's as narrow as you can get upon reasonable medical judgment that the patient in question will die within 6 months. There's certainly no more restrictive ground in operation in the context of voluntary euthanasia or assisted suicide that I'm aware of. And yet, in practice, not de jure, but de facto, how that is operated under Oregonian law suggests that it has expanded. Again, the expansion is not a legal expansion, but it is an operational expansion. And there's a couple of reasons for thinking that. First of all is the issue of misprognosis. So, doctors are aware that, giving prognosis for certain conditions is a tricky affair. It's hard to be very exact. And obviously that's an important point when it comes to time limits, like 6 months, for example. But in Oregon, there seems to be a marked increase in the level and extent of misprognosis that's happening under the law. Now, to kind of infer this information from the reports is a little bit tricky because they don't provide a whole lot of information. So we're only kind of privy to like the outer range of misprognosis cases. And that's what I based my main findings on in the article. So from 20 to 22, there were 35 reported cases of patients outliving their 6-month prognosis. So it's the same term limit in Oregon as is proposed in the Leadbeater bill. And that's half of the reported total of all such cases from 1998 to 2019. So again, that's a massive, proportionately speaking, that's a massive increase in cases of misprognosis in the last number of years. And the 2023 figure, again, is at the very upper end. The 2023 figure is 17 cases, which is the same as the figure for 2022. So, I mean, this is only, again, the acceleration here also is increasing. The figure of 35 patients from 2020 to 2022 is out of a total of 792 assisted suicide patients in those years. And that does not mean that the misprognosis rate was only 35 out of 792, which would be 4.4%. It means that the misprognosis rate was 4.4% at an absolute minimum. These patients were dying by assisted suicide. They weren't dying naturally. And obviously, someone can be misprognosed and avail of assisted suicide long before their illness would eventually take their own life. So it's impossible to tell how prevalent misprognosis were for those that died by assisted suicide before the 6-month prognosis point, which would be 95.6% of patients. What can be ascertained is that marginal misprognosis by no means exhausts the cases of misprognosis we know occur. Oregon provides very limited data on the duration between the first request for assisted suicide and its eventual occurrence, the most relevant of which data is the outer range of the duration, i.e. the longest duration between the two time points. The average annual farthest end of the range for the years 1998 to 2018 was 536 days. So that's circa 18 months. That is to say, on average, per each annual report, the longest duration between an initial request for a lethal prescription and death by assisted suicide, not by the terminal illness, okay? So again, we're not even getting a clear view of how badly misprognosed the illness is, was around a full year beyond the 6-month terminal prognosis. Every year from 98 to 2018, bar 1998 itself, had a longest duration well in excess of 6 months. But the average longest duration for the years 2019 to 2022 constitutes a very sharp increase, 1,384 days, circa 46 months. For these 4 years, the annual longest duration was on average over 2 years beyond the 6-month terminal prognosis. And again, the updated figure from 2023 is at the upper range. Okay, so again, clearly the extent to which we've got drastic misprognosis happening is increasing, it seems, according to the 2023 report. We're dealing with one outer range figure per year because that's all the data provides. It's not very helpful. But it would be a little bit naive to think that if you've got in each year drastic misprognosis of at least 50 months, 36 months, 37 months, and 62 months, that every other case of misprognosis is a marginal misprognosis. It seems that we're, in all likelihood, we're dealing with a subcategory of very serious misprognosis happening. Obviously, this is a medical reality. There's no gainsaying that. At the same time, what the data shows is that it's becoming more and more of a reality in the practice of Oregonian law. And that raises, I think, interesting questions. What's also happening in conjunction with this is that the qualifying illnesses recorded in the official reports themselves have expanded in a direction away from normally, or at least predictably, terminal. So to give an example, cancer accounted for 88%, 63%, and 78% of all qualifying terminal illnesses from 98 to 2000 respectively. In 2 of the 3 most recent official reports, that's 20 and 21, but not 22 and 23, and I'll explain that in a second. They include the following additional illnesses as as qualifying for the terminal illness ground for provision of assisted suicide. So these are the following: non-COPD respiratory disease, endocrine metabolic disease, e.g. diabetes, gastrointestinal disease, e.g. liver disease, anorexia, arthritis, arteritis, blood disease, complications from a fall, hernia, kidney failure, medical care complications, musculoskeletal system disorders, sclerosis, and stenosis. And in these years, cancer accounted for 66, 62, and 64% of all qualifying illnesses, down from 88, 63, and 78% for the first few years. So some of these illnesses, seem dubious or questionable as qualifying on the terminal illness ground. I'm not a medical doctor, but I know there are others who've examined this and who would say the same thing. The reason why we only have, in the most recent number of years, only reports from 2020 and 21 on these illnesses is that in the two most recent reports produced by the Oregon Health Authority, 2022 and 2023, they have ceased to provide details of the other illness ground. They still mention other illness in the data, but prior to 2022 rather, they provided a breakdown of what these other illnesses were, and I gave a readout just there of some of them. And that itself, I suppose, is worthy of comment. I mean, maybe it's a case that it was producing unwarranted attention. Maybe it's a case that those illnesses have been misconstrued by public commentary. Whatever the case is, the most recent Oregon data doesn't provide information on such illnesses. Another feature which, from the kind of morological slippery slope perspective, I find most interesting is that refusal of treatment. It seems to be the case that refusal of treatment in Oregon can be a catalyst for transforming a chronic illness which doesn't qualify under the terminal illness ground into a terminal illness that does qualify under the terminal illness ground. So there was an analysis of the Oregon law undertaken by the Swedish National Council on Medical Ethics. This was published in 2018. And according to this report, it says that the 6-month terminal illness ground is interpreted in practice in Oregon to include, quote, cases where no treatment will be given to inhibit progression of the illness. Subsequent to that, a number of questions were put to the Oregon Health Authority, the following two questions, and these questions received an affirmative response from the Oregon Health Authority. So the Oregon Health Authority answered yes to both these questions. I'll call the questions out here. If the doctor suggests to an eligible patient a treatment that possibly could A, prolong life, or B, transform a terminal illness to a chronic illness, or C, even cure the disease, and if the patient doesn't give his or her consent to the proposed treatment, is he/she still eligible to make use of the act? And the answer given by the Oregon Health Authority was yes. The related question was, quote, if a patient with a chronic disease, for example, diabetes, by some reason decides to opt out from the life-sustaining medication or treatment, and by doing so is likely to die within 6 months, thereby transforming the chronic disease to a terminal disease, does he/she then become eligible to make use of the act? And again, the response from the Oregon Health Authority was in the affirmative. So that's particularly interesting because there's two things happening here in the case of someone with chronic illness who might have an interest in accessing assisted suicide. They can potentially refuse ongoing medical treatment, which is entirely their right, of course, and is a function of their autonomy, and in doing so, ensure that their disease will thereby cause their death within 6 months, which then qualifies them to access assisted suicide, which is also, according to assisted suicide proponents, a function of autonomy. If you're to look again at Oregon's definition of terminal illness, it doesn't rule this out at all. So in practice, we've got good reason to think this is happening, but the definition of terminal illness inherent within the Oregonian law doesn't rule this out. It defines terminal disease as, quote, again, an incurable and irreversible disease that has been medically confirmed and will, within reasonable medical judgment, produce death within 6 months. Now, obviously, the difference between a terminal and chronic illness is that not that there's an irreversibility there, but that the terminal illness in and of itself will cause the death within whatever the time frame. Oregon's law does not define terminal illness in such a way that it precludes someone from refusing treatment in order to translate a chronic into effectively a terminal illness. And that's possibly the kind of legislative reason for why the Oregonian practice has moved in the way it seems to have moved. This is obviously part of a wider slippery slope argument, because even irrespective of this kind of new wrinkle in the argument, this new way of transforming chronic into terminal illness, this new way of maybe expanding the terminal illness ground, there's always the case of why would a regime restrict access to assisted suicide to someone who is terminally ill and will die within 6 months? Why not 7 months? Why not 8 months? Why not 9 months? And more fundamentally, why does it have to be a terminal illness? There are people with serious chronic illnesses, so forth, and there are people with serious, psychiatric conditions as well. And in all these cases, the individuals in question may truly, sincerely, wish to remove their suffering from ending their life. In all cases, at least in principle, they could act with capacity and voluntarily. And if assisted suicide is predicated on autonomy, as it seems to be in terms of most people's justification for the practice, then why should some people's autonomy be ranked lower than others? So that's a real challenge for the assisted suicide proponent, or the narrowly drawn assisted suicide proponent, to parry. Again, it seems to me that when one examines the moral logic of these things, that if you're to kind of forego the principle that it's wrong for the medical professional to deliberately end someone's life, out of respect for human dignity, out of respect for the primary aims of medicine and so forth, then any exception thereafter that's narrowly drawn is going to be arbitrary. It's going to fail to consider the claims and interests of people who are just outside that narrowly drawn exception, who equally want the benefit, as they see it, of assisted suicide. We can't any longer respond by saying, well, assisted suicide is in principle bad, because with the introduction of assisted suicide, we've denied that principle. We can't say that someone's autonomy matters less than another's autonomy. That doesn't seem fair at all. So it's a hard thing. It's a hard thing to oppose once introduced. That's not an operational point. It's not a political point. It's a moral logical point. And I think that's why, if you're to examine the views of most people who are supporting assisted suicide in academia, in Parliament, ultimately their view is that assisted suicide should be available on much wider drawn grounds than that of terminal illness with a life expectancy of 6 months or less. Okay, I didn't want to, and I don't want to speak for too long, because I'm conscious that there are people here who know more about these things than I do, and I think it's good for the discussion to open up to hear other people's positions, questions, thoughts, comments, and so forth. So Anthony, if it's okay, I'm happy to finish up at this point and take questions, and indeed to listen.
Sorry, just get my audio on. Great. Thank you very much indeed. Well, that was a very detailed and thorough examination of Oregon. So thank you very much. Now, if anyone wants to ask a question, you can either put a question now in the chat or a comment, or just indicate to me via the screen or with an icon that you'd like to ask a question. We had a couple of comments from Francis, so maybe I'll just start with them. They're in the chat. The first one I mean, this was while you were speaking, is it a slippery slope, or is it the logical progression of a change in the law? So is a distinction to be made there, I think is the question.
Yeah. Yeah. Will I address that, Anthony? Or try
Sure,
to?
sure.
Yeah, I think I think if this is the sense given by the Francis's question, I think in a sense the kind of the phrase, the term slippery slope is a misnomer, because when we think of slippery slopes, I mean, nobody wants to be on a slippery slope, and if you fall down a slippery slope, it's certainly unintentional, isn't it? You don't want to get to the bottom of that chasm. I really do think it's really a matter of moralogical progression. It's really a matter of, abiding by the principles one has now embraced, and seeing clearly that the old arguments against assisted suicide no longer hold. So it's just a funny thing to listen to the debate in the Irish Parliament and listen to some of the questions that were posed and things that the members of Parliament were saying in the context of the discussion. I had when I was up there, and they were talking about the need to make this narrow, and we have to be careful that it doesn't expand. And people who were saying this were looking to introduce some form of assisted suicide. But leaving coercion aside, it just struck me, and I had this in my written submission. I mean, why would you want to restrict this if you introduce it? I mean, okay, we want to have protections against, let's say, outright coercion of people, because that's inconsistent with the principle of autonomy. Assisted suicide is meant to be based on the principle of autonomy. But if it is based on that principle, then why would we restrict it to people who are also autonomous and also have a clearly defined, settled, sincere wish to end their lives in order to end suffering? Again, it just seems a strange thing. It seems a lot of times people are caught between, the old morality and the new morality, so to speak. They're caught between two principles. But if we allow it in principle, then to want to restrict it in practice, and say, you have to die within 6 months, it seems incredibly arbitrary to me. I've never seen a case properly made for it. In fact, when one examines the philosophical literature on this, anyone that really engages with the point seems to concede this. So Joseph Raz, the great Oxford moral and legal philosopher, wrote around 2011 on this issue. On exactly this point, proponent of assisted suicide and voluntary euthanasia, and just said that, look, you have to be clear-headed about this. I mean, if we introduce it, it's because it's good. And if it's good, why should we restrict it? The principles that sustain its introduction sustain its expansion, in effect. I'm paraphrasing Raz there. Badly.
If I can just add to this, I mean, a couple of things. A student actually said a number of years ago, I was talking about slippery slopes, and he said, I thought they were a fallacy. And there's quite a common thing, certainly in this country, where even the mention of slippery slopes, people say, oh, well, that's just a fallacy. And then don't listen to these very serious arguments from, as you say, people like Raz, Bernard Williams, people from across the political spectrum, you might say, who do recognize that this is a very serious matter. But one kind of argument might be, there's sometimes a debate about the Elgin marbles in the British Museum, whether they should go back to Greece. And some people say, well, if you do that, then everything in the British Museum is going to be demanded and go back. And there are quite a lot of social practices a bit like that, where, it is to some extent arbitrary, but nevertheless, people settle for it, and they say, well, it's a bit arbitrary, but quite a few things are. So I wonder what you might say to someone who argued like that it's all very well and they can appreciate the principles, etc., but in quite a lot of cases we do muddle on one way or another, and it's not the end of the world.
Yeah, well, I don't think every slippery slope argument is necessarily a good argument. Whether we're talking about end of life decision making, or the practice of keeping some other countries' artwork, that's not an Irish problem so much.
Yeah.
But I think if we examine what's being claimed in assisted suicide, it's not been introduced on the basis of a regrettable compromise or under the category of tolerating different views and sub-ideal medical practices. It's been introduced under the auspices of a very thick autonomy right and presented as a right in a very strong sense. So I mean, straight away, the case just doesn't parallel. An exception may be made to the keeping of certain artifacts with a country that one might have a particular history with. No one is claiming that every artifact that belongs in a museum it rightfully belongs as a matter of principle elsewhere. But in assisted suicide, we are claiming a right. It's coming under the rubric of rights. And not just any right, but for a certain form of liberalism, the most important preeminent right, which is authenticity and autonomy. And that's why, if we accept that principle, so much falls away from the presumptive case that was in place against assisted suicide. I think a much better parallel is the case of abortion. Obviously, there are different issues, but just in terms of slippery slope argument, there are very few philosophers out there. There are very few legal regimes out there that, once the principle is embraced that the fetal life is non-personal, that we should have serious restrictions that really prevent access to abortion in the course of pregnancy. And I think assisted suicide is much more like that.
Okay, thank you very much. Okay, so I'm just going to the chat. Give me a second.
Where are you looking at the
So
chat?
Anulika was asking what was the percentage of misprognosis initially and now in Oregon, if you can recall that from
that's a good question. It's questions to do with numbers. I can't say I'm.
By the way, I put a link to the paper up in the chat,
I put it
so
to the paper.
everybody can access the details.
I'm not sure. We can't answer that, and just simply because the only way we can tell in Oregon if a misprognosis has occurred is if the patient doesn't avail of assisted suicide until after the 6-month window, the 6-month prediction of their death has elapsed, if you know what I mean. Most people will avail of the lethal medication within the 6-month time frame, and we'll never know if there was a misprognosis. We can assume that in many cases there won't be. We can assume that someone is more likely to avail of the barbiturate if they are at the end of the road. We can assume that, but we just simply don't know in most cases. We only know when a misprognosis occurs when the person avails of the drug after the 6-month prognosis point elapses. So they hold off. The doctor is wrong on the 6-month limit, the hold off, and then maybe a year later or 2 years later, they take the barbiturate. Then it's registered as assisted suicide. And at that point, we're aware of that data. We're aware of it as taking place after the 6-month point. And we're aware if it's a misprognosis. We still don't know how bad of a misprognosis it was because the person died by assisted suicide and not by natural causes. So I've sort of tried to be careful in the paper to kind of say there's a limit to what we can know, but I think we can extrapolate something and say that it's getting looser, and the kind of the extent of an individual misprognosis seem to be getting a lot more wide, a lot more inaccurate. Whereas you'd think, presumably, a doctor can fill us in on this, you'd like to think that misprognosis cases wouldn't be as widely inaccurate now as they might have been 25 years ago. I imagine Oregon is a well-resourced state, and that there have been developments and improvements in diagnostics and prognostics and so forth.
Okay, thank you. And actually, Anuka has added later that the diagnosis of dying tends to be very arbitrary amongst medics anyway. So as a further point.
Yes.
Sorry, Adrian has added, sorry. So Adrian has asked, that those who are pro assisted dying or assisted suicide say that Oregon's okay, despite that here the NHS permacrisis and current procurement of death to clear beds, which will accelerate. I take that more as a comment, but
Yeah.
yeah.
I think that's important. Like the context here is, I think there's a wider demographic context to this, which mightn't determine the issue maybe one way or the other, but it certainly can't pass a comment. And I know there's been recent reports in the UK on this, and there's been recent reports in Ireland, and we're aware of what's happening in Europe and so forth. I mean, we were at a certain kind of demographic tipping point. Like the percentage of older people that's going to be in our society going forward will be much greater relative to the percentage of younger people. One doesn't need to kind of stoke their imagination too hard to understand the sorts of pressures that might create on people as they become older, with their younger relatives who, mightn't have a guaranteed pension themselves and so forth. There is a financial backdrop, a financial reality to this, which means that, and this may well be what's happening a little bit in Oregon already, for example, which means that assisted suicide being introduced now will probably have more drastic social consequences than if it had been introduced 20 years ago in this country, I would suggest, just looking at the demographics.
Good. Okay. Karen has asked, is there any data on the socio-economic class and ethnicities of people who have opted for or had assisted suicide in Oregon or elsewhere in the world?
Yeah, great question. There certainly is. I didn't cover it in my paper. I'm not terribly au fait, but if you can get all these reports already available online on the Oregon Health Authority website. Just Google dignity with dying or death and dignity, Oregon Health Authority, to get the reports. And there are categories like marital status, race and ethnicity is there, age, education. I'm not sure if there's anything directly socioeconomic. Probably a hard thing to categorize or even ask for information on, but certainly one could infer certain things from the data. So like, for example, under the education category, the level of qualification they have from 8th grade or less all the way up to doctorate, and you can probably extrapolate from a lot of that.
Okay, thank you. Robert has asked, do patients receive assisted suicide, I assume we're talking about Oregon, as one option following being told that their illness is terminal? So is it presented to them in Oregon, I think is the question, once the diagnosis is...
Yeah. The act itself doesn't provide for, let's say, mandatory notification of assisted suicide upon diagnosis of a terminal illness.
Okay.
So obviously in practice, one would assume that if this is accepted as it is, if this is growing in popularity as it is, that in the training of clinicians, and just in the wider ethos of the healthcare system, it would naturally be the sort of thing that would be raised. We know, for example, it's been raised in this form in Canada. There's all sorts of reports as to what's happening there, including in ways that are just inappropriate by any standards. But it's not provided for in law, and in practice, I assume it is, but I can't be certain that this kind of automatic notification is taking place, or generally taking place.
Okay. Okay, Dr. Adrian, I think, is listening. I'm just wondering, you have experience of end-of-life care, I believe. Would you like to tell us something about that?
Well, I'm a rheumatologist, so I don't see massive amounts of end-of-life care. But I mean, I've quoted you in a letter today without referencing you, because the undefined arthritis, I mean, what kind of arthritis is really terminal? It's rubbish, total rubbish. Arteritis is an inflammation of blood vessels. That's an old term. Again, a lot of that is very treatable. And to be quite honest, it beggars belief. The problem is, though, from my aspect, we do see sick patients. And the examples I will give with a sick patient in their 50s who had lung and kidney disease, relapsed. And in Oregon, they might have been offered, they might have been told they've got 6 months to live. But in the UK, they had a DNA CPR order. Their family were told it's futile resuscitating them. They're going to die. And the answer was they weren't going to die. They were alive 12 months later. They were on an ITU. They'd had no expert opinion whatsoever. There were new drugs available to treat them. And when I left 12 months later, they're still alive, and I got them to somewhere else so they would get better care once I left. But the honest answer is, it's the UK and the NHS perma crisis. It's all about clearing beds and also about gaming statistics, which it isn't the same in Oregon, I don't think. But in the UK, it's about gaming statistics. So if you say you're going to die and you live, well, you code the episode in the NHS as palliative care. And so in the hospital I'm talking about, the worst mortality in the country went down to average in 2 years, full stop. So, I mean, I do see a lot of people who actually have severe conditions. And that patient I've just told you about, when he went back to the ward, the person who was actually responsible for him being sick said to me, how can this man go on with this disease he's had for 12 years? And this was somebody who should know about the disease. It was in his area of expertise. I simply said, well, you treat him. So the problem about the NHS is it is the lack of capacity and trying to make a bed. And the fact that there's a universally pessimistic prognoses, and it's for specific expedient reasons. Sorry, that's a long spiel, but
No, it's extremely valuable to us. Thank you.
Yeah, I think that's really important. I mean, it's the same in our healthcare system in Ireland. It's really coming under strain in the last number of years. The proportion of exchequer funding that we direct in towards health has increased dramatically, but all we're doing is maintaining capacity. We're not really increasing capacity a whole lot. As far as I understand it, Professor Patricia Casey is on the call here. She might be able to come in, but of course our population is increasing and getting older, and we can't be conspiratorial about these things, but nor can we be naive. It is something like assisted dying will prove, at least at some level, attractive towards for administrators facing a massive logjam in healthcare provision. It's the sort of thing that it would be silly not to promote if legally available, at least for the secondary effect of freeing up resources, beds, time, and so on. And again, I think it'd be naive not to notice that.
So when you had COVID, you probably thought, when am I getting over this? I feel awful. Am I going to die? Can't this come to an end? When you say that in an NHS hospital now and over the last few years, people will alight on it and say, well, they're dying, aren't they, etc. And during COVID, there was a patient who damaged his mask. The nurses were very annoyed about him damaging his mask. So the junior doctor arbitrarily said, he's dying. The only problem was he took a very long time to die. So he had COVID, but he wasn't as bad as they said. But he took a long time to die. He wasn't dying. Yeah. But the honest answer is it's worse actually elective care is worse in Northern Ireland than you'd imagine, because actually a few doctors are coming south of the border for financial reasons.
Right.
Okay, that's very interesting. Francis has his hand up. So,
yeah, hi. Thank you for this, Tom. This has been very helpful. I just going back to my question about logical progression to start with. I think the language that we use in this debate is really, really important. And I think logical progression is about people being discriminated against. And I think it's important that we help people with the language. And I think, the supporters of assisted dying in England they're talking about assisted dying, but for me, assisted dying is palliative care. What we're actually talking about is physician assisted suicide. And I think it's very important that we use that language. I've spent 30 years working in both adult and children's palliative care. And during those 30 years, I've only been requested to euthanize a child by the parents once. And in actual fact, I'm just going to go back to Adrian here, is that this family felt that their child had died, that had an event and was no longer their child. And they thought the kindest thing to do was to put their child to sleep. But as I said to them, we just need some time. Just need to give your child some time to come through this. And 6 weeks later, the father stopped me on the stairs of the hospital and said, "I need to apologize to you." He said, I was very rude, very angry with you when you came to speak to us. But he said, tomorrow we're taking our child home. It's not the same child, but it's our child. And I think the language that we use is really, really important to help educate people around this.
Yeah, I agree, and it's a powerful story.
And just the other point was about coercion. And I think that coercion, it's a lot of internal coercion from individuals that push them to that place of being a burden, or feel that they're a burden and want to end it.
Certainly, coercion and pressurization, their actions, behaviors, emissions, so forth, that exist in a spectrum, and then very often it can be quite subtle. It could be a comment about impending financial realities made in passing, but made sure that it was heard, for example. And I agree completely in terms of the language. Assisted dying really is palliative care, and what's been taking place here is, or what's been advocated and proposed, is assisted suicide. It is a form of killing. Killing is woven into the fabric of what's being proposed.
I think they've adopted this language to make it more acceptable to the public.
Yeah.
But it's a smoke screen. It's a smoke screen.
It's dishonest, I think, and that's why it's one of the reasons I used to work in Irish politics in the Irish Parliament. And one of the liberating things about academia is that when bioethicists will talk about these things, even though they're completely in favour of assisted suicide or voluntary euthanasia, they'll just be upfront and honest with what exactly is entailed. And I think that's a very important thing for public discourse. And obviously there's no greater crucible for public discourse than Parliament, and so it really is a betrayal of that public good to dress up assisted suicide as assisted dying.
Thank you. Okay, so two sort of related questions. One is from Anulika. Do you know anything about the expectation on doctors to assess patients for assisted suicide in Oregon, and how conscientious objection works? And she's adding, especially if there are expectations that the doctor will refer a patient to another doctor. Is there information on how doctors conscientiously object in practice, and if in reality doctors get into problems with such objection?
In terms of conscientious objection, off the top of my head, I think it's provided for in the Act. I'm not sure, and I could be wrong on that. In terms of the question of the kind of the steps taken, or the stages which the patient and doctors have to go through before signing off on access to assisted suicide, there is a requirement. There's some kind of requirement to get a second opinion, as far as I know. I'm not as certain as I should be on it, because that wasn't exactly what I was focusing on. But a related point that comes up just now that the question has been asked is that all the Oregonian data is collected ultimately via self-reporting. Okay, and I don't know what's in the Leadbeater bill, but that's really, really important, because there's absolutely zero incentive for a doctor, or indeed for a patient, to let's say own up truthfully to what exactly the condition is. or one up exactly to the evidence given for the basis of the decision. So the only way a doctor in Oregon is going to fall foul of any professional standards over this is if he or she says, look, I signed a form when in fact I knew I shouldn't sign the form. So it's just not going to happen. And obviously the patient's always going to die once this happens. So they're not going to be around to complain or to give a different perspective. And there's no kind of there's no review mechanism. There's no transparency mechanism provided for in the law. So it would stand to reason that it's the sort of thing that could be exploited in different directions. Anyway, it'd be interesting to know if that's what's happening in the lead beater bill or what's provided for there. That could maybe counteract some of these concerns. And just the person who asked the question, again, apologies, I couldn't give a particularly great answer on it. But you will be able to, if you just go to the law itself, you find the law, the Death with Dignity Act 1997, you'll be able to find out exactly what's required. And I think both things are mentioned that the person asked of.
Okay, there's a comment from Helen Watt, relevant here. It says the lead-beater bill requires referral if the doctor doesn't want an initial discussion. So presumably an initial discussion could be factual about legal possibilities, but not recommend going down that route. So I think that's... and Adrian has added, in lead-beaters, conscientious objection is contrary to GMC guidance and 2022 revised International Code of Medical Ethics, i.e. specifies the need to refer on rather than inform the patient. Right.
So that involves some level of cooperation.
Yeah, I think.
Yeah.
Very much. And Karen has observed that Leadbeater's title of her bill ends with words from memory and connected purposes, and wonders how that conveys how tight the safeguards will be. So, telling phrase.
The issue of safeguards, if I could just come in there, Anthony, again, when we think of safeguards, it's just a point worth reiterating in relation to assisted suicide, we, let's say, the royal we, would think in terms of, well, how can we make this as limited as possible? But within a pro-assisted suicide framework, where it's seen as in principle good and connected with genuine rights, all safeguards mean is the prevention of strict coercion. So everything else is on the table, and so safeguards don't apply. So very often when you hear, let's say, two MPs debating this issue and they're talking about safeguards, it might sound like they're in total agreement, but depending on the framework they're operating within, it can mean two very, very different things.
Well, I think actually further on the coercion point, I mean, a much deeper level of coercion is that the very introduction of a legal option introduces in itself a kind of social pressure. And we're aware of those things in all sorts of areas of our lives. And obviously here it's very radical. Because immediately the question is, well, why aren't you doing X? When X is now seen as a publicly endorsed, legally sanctioned, medically sanctioned option, i.e. a good option, or an option that is in some way not bad.
That's a really important philosophical point, because for any of us here currently, to, let's say, to will against assisted suicide, that's a totally different form of action in a sense than the sort of willing we would have to do in a context where it's permissible and in some cases promoted. The presumption changes, the texture of the question changes, and it becomes harder to resist, because, as you say, the follow-up question is, well, why not? Especially given all these other people that stand to benefit and the system as a whole that stands to benefit if you just do the honourable thing.
Yeah. Good. I think Patricia, Professor Casey wanted to ask a question. You're muted at the moment. Yep. Oh, you're muted still. Yep.
Right. There we are. Thank you. I'm sorry, I don't see the hand icon on my screen. I can't find it. Just another aspect to the Oregon situation is suicide, unassisted suicide, and that has risen slightly as well. And there's a study by David Patton, which I'm just looking at here, is assisted suicide a substitute for unassisted suicide, in a paper on in the European Economic Review, published in June 2022. And David discusses that in a very interesting paper in a non-scientific journal, in a political journal called Spiked. I'm sure some of you read it. It's the Andrew O'Neill Free Speech Journal, and it's available free online. And David Patton wrote a paper for that publication just a few weeks ago, and it's worth looking. And he makes many of the points that Tom has made there. Yeah.
Thanks, Patricia.
Thank you very much. Yes. So a comment or a question from Rosa. The reality is that most people have an uneventful death. From my experience as a doctor working in palliative care, patients were reassured to have it explained to them that. So I'm waiting for the rest of the message.
Sorry.
We can just say it. Yeah.
To have it explained to them that they weren't going to, for example, die from being short of breath, that they could have medication to help them and a lot of support. And I think what is lacking actually really is that all doctors, we talk about palliative care as though it's a specialist thing that should happen in a hospice. The reality is that all doctors and all nurses should be able to give terminal care to patients. And that isn't talked about. It's made out as though it's a specialist thing. And because we don't provide it enough, we don't seem to have the resources. Therefore, the alternative is to physician-assisted suicide. There doesn't seem to be a middle place for people to go. And that is education of doctors and nurses, and also to train doctors and nurses in the art of communication and listening. It's very simple, but it's also very important. And I think a lot of this wouldn't need to be talked about if that was if medical nursing staff were trained in that way and given the resources.
Can I ask Rosa, or in fact other people who work in palliative care, has there been a shift in palliative care to a more pro-assisted suicide position or assisted dying position, or not, in the last, say, 10, 15 years? No, I'm seeing a shaking head somewhere. So yeah.
I don't think so. I don't think so.
Okay, that's interesting.
I think, people are saying actually the provision needs to be better. And if the provision was better, we wouldn't be then having this ongoing debate about people dying in uncontrollable pain. And so I think there's two parts for that for me is, these stories that we hear, did that person have access to palliative care? Did they have access to specialist palliative care if they've got really difficult pain syndromes that people are struggling with locally? As Rosa says, it's a part of every nurse's and every doctor's it's everybody's business, palliative care, end of life care. I've just lost my train of thought there. I think, but what we're saying is that actually there needs to be better provision. So I live up here in Orkney, which is the home of Leah MacArthur, who is sponsoring the Scottish bill. But a home death here, where I live on the island that I live on, isn't safe, isn't possible, because we haven't got the palliative care. But if we had that palliative care, then the possibility of a home death would be much more available, and people wouldn't be thinking about taking their own lives or asking somebody else to take their life for them. But it's about the provision. We need better provision.
Thank you, Francis. Sorry, Andrew Martin, sorry for the wait. you could ask your question.
That's okay. It's two comments really. I work in a hospice. I was a nurse for 25 years, but the last 14 years have been a hospice chaplain, and we've held some like drop-in sessions for staff to discuss the implications of this bill if it's passed. And just talking about what you're saying, has there been a shift? One of the members of staff said, are you prepared to lose the majority of your staff if this bill is passed, and if you are offering assisted suicide in a hospice? So I thought that was very telling, that the majority of staff would not be comfortable with this and would leave. And the other thing is talking about conscientious objection. One of the things that was discussed, one of the doctors that gave a talk was saying that you're not allowed to conscientiously object in New Zealand because assisted suicide there is seen as healthcare, and you're not allowed to not give healthcare, which I found very, very worrying indeed.
Yeah, that's very striking.
I think also talking in my 25 years of nursing was looking after people with dementia that had so-called challenging behaviour and couldn't be nursed anywhere else. And then in my 14 years as a hospice chaplain, it's very rare that people have asked or said, is it that you wouldn't let a dog live like this? Can't you give me an injection? Can't you finish me off? And the odd occasion that relatives have said that, particularly with people with dementia, when that person actually then has entered the dying phase, they've said you've got to treat them, you've got to give them whatever medication you can to keep them going. So it's the people that have said that change their tune when that person is actually dying, and often they'll say it's obvious they don't want to die. They're fighting against this. So I think that's very and once people are given good palliative care, they very, very rarely, in my experience, ask for assisted suicide.
Well, thank you very much, Andrew, and thank you all of the people, particularly people sort of working on the front line of this issue. It's obviously getting very serious. In 8 days' time, we have the second reading of the Leadbeater bill, which Tom referred to, and which clearly takes Oregon as a sort of model in some ways. So I think just to refer you again, if you want to make a donation, there's the link at the donate page. But I'd like to thank very much indeed Dr. Tom Finegan for a very thorough and enlightening talk. So a virtual round of applause.
Thanks very much, Anthony. Thanks very much, everybody. Hope it was of some benefit, and delighted again to be invited. I wish all at BIOS the very best. It's a great organisation, and I think it'd be great for such organisations to flourish and grow and reach. So I wish you the very best in your important work.